Hi everybody, Dr. Megan here today. I have a patient with me. We're going to be treating her lower leg here. So this is kind of an interesting patient. She's a little bit younger than a lot of folks we get in for regular physical therapy, but she's coming post-surgically. Sam, you want to tell them, you've had 2 surgeries on this ankle in the last couple of years. You want to tell them about the most recent one back here?
So I had osteogonum excision and FHL repair over the summer, which is just like removal of the osteogonum, which is a little extra bone in the back of your heel.
She said it's an extra bone. She has a weird little extra bone in the back of her heel. Most people don't have it, and most people who do have it don't have problems with it. Right, Sam?
Right. Exactly.
And then she was going to tell you, before I cut her off, that she had it surgically removed. So she did have problems with it, and she had to have hers cut out. So it's kind of an unusual procedure. And she's had that done on both sides. So this is the older one, and this is the newer one. And then there's another surgery. You can see the scar over here. We're starting to treat along this band of muscles here, the peroneals. You tore that one too, right, Sam?
Mm-hmm. Yep, I had my peroneal repair like 5 or 6 years ago.
So she had a peroneal repair 5 or 6 years ago, she said. Do you have that on the other ankle too, or just this one?
I had it on both sides.
She had it on both sides, that's what I thought. She likes to do it right. She wants to have it all. So this tissue is really tight and restricted around here. You can see I did some highlighter marks. You guys see this yellow stuff? That was actually me. Before we brought you in, I was poking around and feeling around and seeing what was going on in Sam's leg. And once I start putting needles in there, she's not going to like it very much if I'm still poking around and digging around in those muscles. So I just made a couple of marks for myself of the areas that I wanted to treat. So we're going to go up along this line of muscles here, treating this attachment. Your peroneal muscles or your fibularis group, depending on where your anatomy teacher went to school. It's the same group of muscles. It's the group that runs along the, ooh, nice muscle twitch there. She's feeling that one. It's a muscle group that runs along the side of the ankle. It brings your foot in that windshield wiper motion out to the side and up. How'd you tear him, Sam?
Playing soccer.
Ah, soccer injury. Lots of ankle injuries and knee injuries with soccer. Okay, so we're just gonna go right along this bony, ooh, wow, I can really feel the resistance in that needle. I don't know if you guys could tell the difference in that. I'm starting to move a little further up where there's gonna be a little more real estate for me to work with. Right now I'm using what I would consider relatively short needles for someone as muscular as Sam. You can really see how the tissue is puckering around the base of that needle. That's indication of how much resistance is happening. You guys have a lot of shadow there. I'm going to go up a little larger size of needle now. I really want to try to treat as much of that muscle as I can. Hit as many of those fibers. Every muscle fiber that we treat is getting increased mitochondria production of energy. It's getting a lot of mitochondria stimulation. And muscle cells can have multiple mitochondria in them. There it goes. You guys see the change of that? Oh, it was giving me a lot of resistance, and then it went on through into the deeper layer. You have 3 layers of muscle here that we're treating. We want to make sure we have the right size needles to be able to get as much of the tissue as possible. So this patient, she's been doing great. She's had dry needling. She went back, she's a college student, so she went back home and had surgery somewhere else, far away from where we are here in Central Florida. And she had dry needling with physical therapy. Where is it? What state?
DC.
Oh, DC, Washington, DC. So she had a really good physical therapist up there who did a great job with getting her post-surgical stuff going. And then she's come back to school and she's seeing us to kind of finish up and get back into her normal function. So we've been working on a lot of this scar recovery. So she's had a couple of different types of dry needling. What would you say the difference is between my technique and the technique you've had in the past, Sam?
Yours is more stationary, so the needles stay in longer compared to the like quicker, like moving the needles around or like tapping the bone or the muscle to release.
So she's had the technique that they call pistoning, where they use one needle and they move it up and down in the same spot multiple times, and then take it out. I was taught to do a more static prolonged hold to put the needle in. And you guys see me doing that twist. Hold on, I'll show you. I'm gonna do another one. I'm gonna get a larger needle. Doing all right, Sam? You're a champ. All right. So I was taught to put the needle in and leave it in to give that length of time for that autonomic system to respond. We're gonna slide that insult into our muscle structure. And if I leave it there, that's like if I just punch right straight through the fabric. Then what I want to do is take that needle and twist it in situ. I'm going to wind it up. Just like if I wind up this fabric, I have a lot more involved in that area. Same thing with the twist of that needle. I go from taking up a 0.2 millimeter space to taking up a more than 50 millimeter space with stimulation using that needle. And that goes down in a cone shape all the way down to the end of that nice long needle you can see there. Look at all that resistance she's given me. That's just tightness in those muscles. And she told me they felt tight all the way up. Oh, she feels the twist today too. You all right, hon?
Mm-hmm.
All right. So she's getting that muscle twitch. She's not particularly upset about it. She gets a lot of change out of this. She's had the two different techniques. She's gotten change out of both of them. She's had only a few treatments with me, so we'll see how she holds up. Okay, I'm guiding that needle. I've got some bend there. There's a lot of resistance in that tissue. I'm going to go even deeper. I don't want to let that filament bend. I want to try and get as deep as I can. Very nice job, Sam. Okay, we'll do one more up along that muscle. We're already up to 75 millimeters, folks. So she's gone from 30 millimeters to 75. And that's the depth of the needle that's penetrating. It's amazing how much meat is between your skin and your bones. Sam and I talked about all this ahead of time, so she was ready for this conversation. Guiding that one in. I don't want to let the needle bend. And that pucker of tissue. And give it a nice twist. Now she's also got a lot of Achilles and calf restriction. So we're going to come back down to where I made my other marks. We have a bunch of wadded, tight, restricted tissue in this area. You can see I made a big box with my highlighter marks. I'm going to treat that area. So I'm going to sink a few needles in there. Oh man, see that bend? Tight, tight. Oh, okay. Change in the texture there. I could feel that shift. How did it feel to you, Sam? Was it tender?
Mm-hmm.
A little bit.
Not too bad.
All right, so these Achilles tendons take a lot of stress. You've heard of Achilles tendon ruptures and tears before. It's a big, meaty muscle, your calf too, as a matter of fact, your gastrocnemius and your soleus together, making your gastrocnemius soleus complex, which comes down, attaches all together into the Achilles tendon and attaches onto the back of your heel. It's going to be a major problem area from everything from hammer toes to plantar fasciitis to knee pain. Sam's, I think, is most likely post-surgical related, possibly sports related. She might have a small tear in there that never got diagnosed or treated. This would be the best way to treat it anyway. Doesn't really matter what we call it as long as we can improve it. You can see it doesn't look like there ought to be that much space, but you can see how those 50 millimeter needles just go right in. Nice. There, we got a nice bony finish there. So we got all the way down to the hard structures underneath. Nice stimulation, even an osteopathic stimulation there by getting it all the way through. Do another one just below it. Ooh, can you guys see that? Lots of resistance there. Bendy needle. It's gonna go for me though. Nice. Muscle twitch. We know we get lots of change out of those. All right, and then she had